Pledge allegiance to the flag. I
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. It doesn't look like we have any public comment this evening. So we'll go on to the consent agenda items. Has the board reviewed these? Okay, I'd ask for a motion.
I will move that we approve the consent agenda as presented.
Moved and seconded. Those in favor?
Aye.
Aye. Passed, thank you. Financial report, Cheryl.
So we had a good month, right there. Pardon? Good. Is it on the agenda that way? Oh. We should have done a resolution when we did the budget approval at the last meeting. So we did not have that resolution, and so we were hoping we could do that this time. So I think you do
We
it.
all got the resolution.
And you signed it.
They will sign it.
They will sign it tonight, okay. So since you already voted on it, I think we just need to make sure you can sign it for all of you.
It's all voted on.
You voted on
You
the
voted
budget,
on
but you
that.
have to approve the resolution.
Oh,
I move we approve the resolution 2016-2, the budget approval for this year.
I'll second that.
Moved and seconded, those in favor?
Aye.
Aye, thank you. It's approved.
all right.
Blue Rose Financial Advisors, I don't think are gonna be here tonight, is that right?
They're not. We are working with them. We're gonna talk to them Monday. They've been in contact with Fed. Things are going well, but we're not as far as, we're not really ready to present the information to the board yet, so.
They asked for some additional debt testing information, but they didn't anticipate, their comment was, they're ready to move forward quickly. Excuse me, Washington Federal was ready to move forward quickly. And we should have enough information August 4th for board meeting. We just didn't have enough information for you to make all the resolutions and have presentations that would make sense for tonight. That was the reason I didn't do that. The other thing that we've talked about, just so that you are, as we talked with them last week, Washington Federal, if you recall, a year ago, when we talked with them about a loan, we did not put it up to all the other banks. We essentially took Washington Federal because we felt that the rates were good and that they had been a long-time partner with us, and that it was prudent to just talk to them. In talking with Blue Rose Consulting, we're not absolutely certain where they're going to recommend. They're still on the fence whether we put it out to bid, if you will. If you do that to various different banking entities, there's a cost and there's a time factor. That cost and time factor may not justify the difference from what Washington Federal has already offered. They're testing the waters, but they also said in their note that that Washington Federal appreciates the opportunity of the first look to open negotiation on terms, pricing, and improve existing additional debt test provisions to include prospective revenue for strategic hospital investments. So we should have by the next board meeting adequate information. So it's not like we were just sort of putting it on. There's a lot that we're doing on this. Okay? Any questions related to it?
No, and I think it's worth the time to put it off if they're not quite ready to give us a presentation, because for me, that's a big report.
Absolutely. As an aside, John from Blue Rose Capital said, I'm sure you've been following the market since the Brexit event, including the remarkable drop in interest rates assuming the same pricing formula that we did for the 2016 bond, as for the 2015 bond, the 10-year fixed interest rate would be 2.72, which is, given current market conditions, they had modeled the new debt at 3%. So, and we got our debt from Washington Federal at just above 3. You recall 3.125 state. So, once again, we're looking at a very good opportunity, which is what we're trying to stay on top of.
Okay. You've got the rapid paying services policy in there, you want to get those out of the way before you get into financial? You want to do your financial?
I don't know, do you want to talk about those, Charlie, now, or do you want to do it later, after that? Because I don't,
Why don't we do the financials first?
that's all right. It's all the same, right? Okay, so, May for the hospital was good. We had 396 patients in the hospital. This is better than last month, we had 345, but it's a little bit less than where we're at for our average this year to date after 11 months at 446. For ancillary, I see, sorry. The losers here were, emergency patients is down 382. But like I've said before, I really don't feel like we lost those patients, they just went to the clinic instead. And we know that surgery was a problem this year, and it's evidenced by that number right there. Our ancillary services down here are all excellent and have been excellent. Positive variances in every category. This number right here, 26% for rehabs, is huge. Home health has been up quite a bit this year, although it's, I mean, this is a huge number, but, and that is a big change, but they still aren't, as robustly busy as they've been in the past, but still good. The clinic is, the health clinic has not seen as many patients as we were seeing. We've had, physicians out for several different reasons, including vacation and education, and so, with the few number of physicians we have, it has an impact. But really, a pretty good month. And then these numbers, I kind of just watch. This number is a little bit high this month, but in general, they kind of stay about where they need to be. Right now, our average monthly revenue is at 2.4 million. Our revenue for May was 2.58 million, so it was above average. It's a good month for revenue. Well, our days in AR, for this chart, I got a couple charts here that I actually included June data because I could. So the current year is in yellow. The days in AR was at 84 in May and it dropped to 80 in June. Collections in May were not as good as maybe they could have been, and in June they're very high. We are still dealing with adding on PCC. I mean, we're billing long-term care out of PCC, so those staff are learning those processes. We're billing clinics out of eClinical Works. So we're adding staff, working with new staff, and existing staff is having to learn new things. So when you add software programs, it does cause slowdowns, for sure.
PCC, just to remind you, is point-click care. That's the software we use in long-term care. And we switched to this software because it is a program that the auditors, when the state comes to inspect us, they're having a hard time finding charting information in CPSI. So they're much more familiar. It's an easier program for the
Lots
staff.
more people use it.
And a lot in long-term care facilities, it's much more common.
Okay, collections on our accounts receivable. The current year on this chart is blue. Our average monthly collections have increased by 102,000 year over year. Our collections for May we're 1.75 million, and for June, we're very close to 2 million. So, pretty good. Days cash on hand. For this chart, the current year is in yellow, this line right here. I only have through May on this one. We are at 140 days right now. Given the collections that we had in June, that number will go up in June from the 140 it's at now. Our profit and loss for the month, we were very close to budget on revenue for the month. We were below budget for expenses. We had a net of $34,000 net gain for the month, which is $25,000 ahead of budget. For the year, our net revenue is just $800,000 below budget. Expenses are $1 million below budget. Our operating gain is at loss is at 1.3 million, which is 265,000 better than planned. Our net gain for the year is 527,000, and it is 428,000 ahead of budget. So it's a good solid place to be, and I do expect June to have probably more positive results than May, and finish a good year. The balance sheet, really AR is up a little bit, cash is down a little bit, but month to month, really no changes. And year over year, nothing to me that is noteworthy. Cash is up. Net is up. So questions on Lakeview? The DME update for tonight, I don't know, were you gonna talk about it or, okay. We're charging right along, and we expect to have the DME store open on June 15th as planned, July 15th, right? July. And we expect the Medicare accreditation to take 60 days or less. We're really hoping on the or less, but we won't count on that.
It is advertised in the paper this week.
Yeah.
Open house on the 15th.
Employee and board member special open house is available from 3 to 6 on the 14th. And then the general open house will be following the 10 to 6, and on Saturday from 10 to 2. As we are opening, making the public know about what our services are, there's a 20% discount. Items that you find interesting. Beg your pardon?
I wish I knew what my husband was gonna break next.
Can you just make it a positive?
Just buy one of everything.
Yeah.
Certainly not encouraging.
I didn't get this.
But
That's still going to be at your real estate office.
it's where.
Yeah, have you noticed the Honker Realty moved to the corner?
16
Oh, the-
North F Street.
Okay,
So right across from Mark.
well, I understand that the real estate,
Honker
as
moved.
of today,
Yes, they have
they did
moved.
move?
Yeah.
Okay.
Oh,
Oh, yeah.
yeah. And they're overdoing wiring and phones and painting and shelving, and they're moving right along.
Okay.
And it's pretty from what I've heard.
Yeah.
It will be a good representation of Lake Health District.
Did you say it was Thursday for employees and board?
That's the 14th.
Talking to Michael, and he said he's gonna let us demo the scooters.
Oh, yes. All those that want to have scooters, or they have all different kinds of fun. He's quite pleased with the speed. What I don't know is if they do wheelies.
He said one was good for a golf course.
Yeah, you have to be careful, Michael. Okay, so Lakeview Gardens had a very good month with patient days at 732, which is well ahead of our average of 608, so they had a good month, and they seem to be keeping their census fairly high, which is exciting for us. Revenue for the month was $211,000, so that is a very big month, way ahead of the average that we've been seeing this year of 159,000. Their profit and loss, which I have been kind of comparing to average because I really don't have comparable numbers for prior year. So compared to April, it was a much better month with more revenue and less expense because there was no tax. So we had a bottom line of positive 44,000, which is awesome. Year to date, it's at negative 55, which is it's looking like it's gonna be well ahead of last year anyway, and you know, so that's pretty close to break even. All things considered, moving in the direction that we wanted. Questions on Lakeview Gardens balance sheet? No change, it just doesn't really change.
You must be running pretty close to full census, right?
Well, actually, we've got 3 beds, I think, available.
We're at 21 right now. So it's not
But we've been at capacity a few
24.
times, yeah.
Well, capacity for having, right,
23.
Yeah.
and lots of patients
One
are quite adamant on having private rooms.
We're working on
Yes, we are. So, Goose Lake Medical, they had revenue of very close to right up to $50,000 this month. So they continue to be below where we need them to be. Tony has started working in Alturas a couple days a week. He'll be down there full-time as soon as we've got another locum FNP will be here to see patients, I think it's like July 24th, and then Tony will be down there full-time. As soon as we get somebody new up here, because with Chris out, we can't lose Tony always. So we also have Dr. Varsakova starting in July. So, I mean, I imagine June won't be super, but July, we should start seeing an improvement. Our loss for the month was 11,000. Our loss for the year right now is at 116,000. The balance sheet hasn't changed. We're still really struggling with the AR balance, the old AR. Charlie and I are gonna go down and talk with Dr. Gilbertson and see what we can do to get some of this old stuff taken care of.
We also had the cost report.
Yeah, but that's really, I don't know that that's the huge piece of this yet, so. Anyway, any questions on that?
One of these days, it's gonna be different.
Very soon.
That is the expectation and the goal, for sure.
Keep in mind that in the month of July, we will have added 2 practitioners, 1 physician, 1 nurse practitioner that we have not had. It's taken a while to get them. That will make a big difference.
Right on, okay. So then the next thing is the private pay services policy.
We sent the.
We all got it.
You all got that information. Do you have any questions about that?
The major changes to this policy was recommendations by the NHC, National Health Corps, that they were mostly due to our financial guidelines, to our financial assistance application. So at the end of the document, they had us make reference to our website. I think we added 6 different items to the end of the document.
It all looked reasonable to me.
Yeah.
Let's go ahead and have a motion.
I'll make a motion that we approve the private pay services policy.
I'll second that.
As per
Moved and seconded, those in favor?
the-
Aye, thank you, Jess. Let's see, item to be declared surplus, and you sent it, or you gave us a copy.
That just came up today. We have a piece of equipment that we're replacing. So they've asked for that piece of equipment in exchange. So we are going to ask you to declare it surplus so that we turn that piece of equipment back to the vendor and then we get it as an exchange.
Also moved.
I'll second.
Moved and seconded to surplus. What is that? A Sysmex CA 540, is that
It's a
right?
piece of laboratory.
All right. Those in favor?
Aye.
Aye, thank you. Motion passed. Nursing report.
Hello. I do have a few things. Did you all get copies of policies?
We got a lot of them.
Yeah, I'm a prolific girl this
Yes, you
time.
are.
Yeah. So the tobacco-free campus policy you signed not too long ago, and then the state came along and made rulings about electronic cigarettes. Up until that time, we had allowed electronic cigarettes. Patients could use them in their rooms, but that's no longer allowed in the state of Oregon. So we had to make changes in the policy. So that's really all there is to that particular one. The policy development and review was for clarification. For the hospital, we kind of worked out what all the different regulations are, and this was developed by Patty Baker Newton and Sheila Gage and myself. So we put all this together with Charlie's oversight, so that this is the final copy on that. I don't know if you have any questions.
I have a suggestion, and Charlie may say it's not decided, no. It appears, and Charlie will talk about it, we're going to end up in the behavioral health business, in order to just add that.
We could add that.
I feel like that's outside of the hospital.
It would be on an outpatient basis. This is really inpatient, so.
It's just inpatient?
Well, it's,
No, you got lab services.
yeah,
All kinds of things.
we do have the hospital. Will it be part of the hospital? I don't know.
Maybe what we should do is move on this and then look at how we're going to, what changes might.
That's fine.
Okay. Next, patients' rights and responsibilities. This was a big undertaking that actually started when the state was here, so it's been going on a while, and it involved, again, Patty Baker and Sheila Gage and myself, and we did a lot of research. And these are the patient rights that patients are required to have shown to them when they register. But there's also some responsibilities that have come about within the state of Oregon, so we added those. So this will change what patients see and sign that they've seen when they
come in.
register. Mhm.
And it look-
Yeah. Is there any
look like we got
questions?
two copies, one's shorter than the other.
One is a handout, so that could be, so this is the actual handout that we would give to patients, and it's what they would sign either on paper or electronically if it's approved by you. And then this is the full-on policy and procedure.
Got a question, Don, did you have a chance to look at that,
I don't think she did.
at this? Yeah,
No,
because that's part of the patient.
family, maybe we should bring it to feedback.
Okay.
Just a thought.
Okay. It's, a lot of it's governed by law, just so you know.
Yeah.
So, okay.
Maybe just for informational for our group so that they don't.
And also how we present it and
Yep.
where it's posted,
Yep.
so, okay. And then the last one, for some reason I still have the copy and I don't have the original. I'm wondering what happened. I suspect
The original.
you have the original for charting deficiencies. So this came to you because it does involve what happens to nurses if they don't correct their deficiencies. So deficiencies are incomplete documentation by nursing staff. And I assume you saw it, so do you have any questions? Do any of you have any questions or concerns? Okay. Do I-
We better have a motion on each of those policies.
Do we probably need to do them independently,
Yeah.
one from the other.
Yep.
Because are we holding the policies development and review, are we bringing that one back?
Apparently, we can do it later again if we want to, but
Well,
let's
If we
pass
make
it
any
in.
changes to
We'll
it.
approve this, and then if they have to have changes for the mental health, let's do it again.
Okay, all right.
So I'd ask for a motion on the tobacco-free campus policy.
I'll move that we adopt the tobacco-free campus policy as presented.
I'll second.
Moved and seconded, those in favor?
Aye.
Aye, passed. Policy development,
We approve the policies development and review policy.
I'll second that.
moved and seconded, those in favor?
Aye.
Aye.
I move that we adopt the patient's rights and responsibilities policy and procedure as presented.
I'll second.
Moved and seconded, those in favor?
Aye.
Aye.
I'll move that we adopt the charting deficiencies policies as presented.
I'll second that one.
Those in favor?
Aye.
That passed.
We're taking turns.
Yeah.
This power sharing right
That was
here.
pretty fun.
You gotta have something to do.
Thank you all.
Thank you.
Thank you. Leslie. Okay.
I do have one more thing.
Oh, okay.
That was just,
That's just
policy.
the tip of the iceberg.
That was only the tip of the iceberg. I brought Nam with me today because we have some quality data for you to see from the acute department. So I'm gonna pass these down. There's two different ones, and you can take one. And I think we're just gonna review this with you. It's been a while. So just
Trying to see who else.
I know Jen needs a
I see.
So there's two things there. I think we could start with the one that talks about medications. So over the past year, Nam and I have had an ongoing project to improve bedside medication verification. And during that process, there's been a lot of parts to this, but one of the things that we've worked on is the connection, electronic wireless connection, that how good the signal is for going down the hall. And then we've also had new computers on wheels or cows that the nurses are using. So as a part of all of that, as well as a part of some of the other changes that we've made through the nurse pharmacy program, there's been a vast improvement in nurses' medication verification rate. And so we just would call out, I think, the bottom piece that shows where we were at in January of that's 2000, isn't that 2015? And so you can see that we started at 38% compliance, and then our most recent report that Nam just completed is at 82%. So, so big changes, and it's really nice, and it's time consuming, and it also represents a lot of work on a variety of people's parts. So just thought that was some good news. Did you have anything else to say on that?
No, just that it has been very helpful for the nurses to see their score, and that's where the improvement came from, on posting their scores in an anonymous way, but there was sort of a competition which got us to improve scores and keep them steady. So that was very interesting to see.
Just out of curiosity, how do you know that they did that?
I'm able to run a report in the EMR in in our electronic medical system, and I can run a report. So if they have not scanned the patient band and the medication, then it will show as it is not done. So that's how we are running it.
The other report, we've brought these to you before, on the Partnership for Patients Initiative, which is the initiative that is co-sponsored by CMS and American Hospital Association. And we've been participating in this particular partnership for about 3 years. And these are our scores on the areas that we have worked on. These are areas that are considered patient harm, so to speak. And so the big move across the country has been to work on things that reduce patient harm as a result of being in a hospital. It's a little bit of a broad definition because they aren't all really exactly like that, but you can see that they're all very important in terms of each patient's stay and their progress and their outcomes. So there are, I believe, 16 different things that you can look at. If they're in green, we're at goal, and if they're in red, we have not met goal yet on those particular things. And due to time constraints, I won't go through them individually, but if you do have questions, I'd be happy to answer them. And Nom knows a lot about this because she extracts all the data and deals with the numbers.
Just something to keep in mind, when we look at us being in red or green, because we are a small hospital and smaller numbers, even one patient puts us in red or in green. So wherever we are in red, I have put the numerator and denominator. So for an example, if you look at number 1, we had 4 patients out of 901, and that put us in red. So it is very difficult for us to be achieving what other big hospital systems are because of the big volume of patients. And we are not that far off from our goal rate, and it's a lot of working with the nurses, CNAs as a team to improve our scores, and we will be working on this moving forward as well.
I thought we'd gone a long time with falls without an injury.
Well, we have had a few that had like a little skin tear as a result of the fall.
Oh, okay. So
And
that
that
counts.
counts
Yes.
as an injury. Luckily, we haven't had any major injuries,
Right.
but
Right.
That's what I was,
yeah.
It's also important to note that this goes from October 2015 to May of 2016. Our time period last month, where we went for, I think it went up to 84 days, of no fault.
right.
That's why it's significant, so most of those falls occurred prior to that.
Okay.
So trying to understand what were the causes. So sometimes you look at trends, sometimes you look at just raw numbers. And as we focus on ensuring that our trend keeps trying to improve ourselves, there's still going to be small numbers. We're still going to have a couple of times things will happen.
And this is a voluntary participation. There are only 21 hospitals in the state of Oregon participating, only 5 critical access, and we are one of them. So we are sort of leading the way with the patient safety, patient harm. So that's great as well.
So if we set the bar real high, we'll be good.
Yes.
We're good. We just want to be better.
That's right.
That is the end of my report now.
Do you want these back?
Either way, I'll take them.
You can keep them.
Sometimes you have all of these back.
Yeah, there's
Oh,
10 times.
that's Patty Baker for the QI program. This is,
Okay.
oh.
Okay, let's move on to Leslie.
All right, so we have an update. I know that we just recently did this as well with our education, training, and travel request and expense reimbursement. What we wanted to do was to do a couple of things, bring this up to date to a federal GSA, standards of what they pay in reimbursement. Ours was a little bit, well, was quite a bit behind. And so we want to be equitable to folks who are traveling when they're out and about, because they don't really have a choice to prepare their meals at home. And so we wanted to make it equitable. The first thing though that we did on the policy, and this was, I'm going to give credit to Jen, brought this to my attention, so we worked on this together, is that there was a discrepancy with the percentage you could ask for in advance. For anyone that was non-ONA related, it was 75%. And in the ONA contract, it's 80%. So we wanted to make it consistent across the board for accounts payable, so they wouldn't have to keep a track of your Teamster or non-Teamster, or your ONA. So we just created some consistency there. Then the other thing that we changed, because we gave a 30-day period to turn in your receipts, and that's quite a bit of a long time. Receipts get lost, and then that creates problems. And so in order to help people be more on the ball, we've lowered the time frame to 14 days rather than 30. And I think 14 is reasonable. I came back from training and turned in my receipts the next day. So I think that's a reasonable request, and it helps accounts payable out as well.
You know, that it's going to be an enormous difficulty for some of us.
Charlie, I'm just gonna filter anything I can say. So.
Well, Charlie, you snooze, you lose.
So we turn around. So then we go ahead, I'm sorry, I'm going back to our meal reimbursement. So we've made some stipulations on the amount as well that you can spend for each meal, because generally they get more expensive throughout the day. So we've upped them to reimbursement to be $50, no meal to be more than $25. And that's including gratuity. And I think that that's very reasonable. Having just come back from Redmond, and I had a salad for dinner, and it was $25 with the gratuity. So those are the changes that we've made moving forward.
Did we get that in our packet?
Yeah.
I missed it somewhere.
So, if I remember correctly, we still have to turn in receipts for each meal?
Well, it was less than $5 you did not, but now we're requiring receipts for each meal,
Everything.
for everything.
If you want to
And-
reimburse, you better have.
Yes, yes.
I just say that, I do traveling for the state and for another organization. And they just say, if you're traveling for us, then you get your meal.
You get a flat per diem.
You get a flat per diem. It
Mhm.
saves an awful lot of paperwork,
Mhm,
and they trust you.
mhm.
And it just makes it a heck of a lot easier. And you just turn in your thing, and then like when you're at a conference and the meal is provided, you just X out, say lunch, and you don't get your lunch reimbursement. That's just how that's done. Maybe there's a reason that.
Well, I think partly too is that we have a policy where alcoholic beverages are not paid for.
Well, this way you don't have to worry about it. You don't have to police that. It's just.
Yeah, that's simple.
We have to change the O&A contract, but I think it'd be worth it. I mean, I think we should look at that
It's just.
in the future, but it's
It
in the
would be,
contract.
we did
Right now,
spend
it's
a
in the
lot more
contract.
money, because a lot of people don't
Spend
spend
it all.
that much. I mean, I used to travel a lot, and we would be reimbursed, and you always said, I mean, you end up making a lot of money off it, because who,
Yeah,
three big
yeah.
meals a day when you're traveling. So, it would definitely greatly increase the cost to the district.
Well, and I tend to agree, and because we are responsible to our taxpayers, I think we as employees can be held accountable to hold our receipts and then turn them in. Because I do agree with Cheryl.
If you guys love, keeping all your receipts and doing all that.
We don't
and it
really have
works,
that
yeah.
much traveling either, honestly.
That's
It's not that much.
I guess it's one half a dozen of another. I don't find it difficult because I'm used to budgeting. So I just consider it a part of,
Who's responsible when who do they turn them into?
Tina Bernanke is the accounts payable clerk.
What kind of time does it take to go through it?
Depends on how long you're gone. I was gone for a day. Didn't really take her. She saw,
Do you provide a cover sheet where they can itemize what they've done?
Oh,
and
yeah,
so
absolutely.
Everything's just stapled together and she
exactly.
just has to, yeah.
She just reviews the
It's pretty
receipts.
straightforward.
It is straightforward. And but then, I'm in HR, so I tend to be a documenter. So I don't feel it's asking too much for people to hang on to their receipts. But that is professional, personal opinion.
What's your pleasure?
This is an accountable plan, I like.
Okay, you sound like an accountant. Is that a motion?
Yes, that's a motion.
Thank you.
I'll second that.
Moved and seconded. Those in favor?
Aye.
Aye. Scholarship proposal.
All right, so we are facing, staffing shortages all over the place when it comes to our patient care positions. And so I'm not sure who came up with the idea. Was it you, Teresa? I want to kind of give credit. I know. Well, so the idea was thrown out there that why don't we provide a CNA scholarship for individuals? Because a lot of times people would like to get into the CNA program, but it's a 5 to 6 week program and they cannot, it's not economically feasible for them to leave their job and go into a program for 6 weeks where they're not earning an income. So we put a committee together that consisted of home health, acute, long-term care, along with myself and Charlie and Larry, of course, as the administrator in training. And so what we wanted to do was outline our proposal and what we've come up with and our idea to maybe help with our shortage of CNAs by providing, it would be more or less, it would be a scholarship and it would be paying out wages for these individuals so they can complete the program. So the course is 5 to 6 weeks in duration, up to 8 students in the class. We talked about the amount of scholarships and who's eligible, and that would be determined by the department directors and Charlie based on needs. How many scholarships do we need per year? Well, that'll be based on the needs, which is constantly changing here. It's a little bit of can be a little bit of a revolving door, especially with our CNAs. So that'll depend on the needs of the departments, and then obviously the directors, the CEO, will assess the financial availability for those programs. We have a cost breakdown, which includes the instructor's time, how much the book costs, and then there is a cost to take the class of $350 that we will absorb. So the cost per student for the hospital, just for the class itself, is a little over $1,200. Then we do a background check, there's a drug screen, and then we'd be paying the wages to the student as their scholarship, part of their scholarship. So the total cost to Lake Health District would be right around $2,700, a little over that. The program outline is they participate in 155 hours to complete the program. 53 of those hours are online education. And we really have no way to track whether, if it's taking them 53 hours, or you might have a smart cookie on the, in the training program, and it might take them 38. But regardless, if it takes them 53 hours, or it takes them 63 hours, or 43 hours, they will be paid for 53, because the program design says that it takes 53 hours for the online education. 27 hours are in lab exercises. And then we do get a benefit, a direct benefit in a long-term care in the hospital for this, a direct patient care. 75 of those hours are clinical hours. Well, they'll be providing care to our residents. So we looked at the criteria, high school diploma or equivalent, 18 years of age plus. We'll have a pre-process screening. We'll look at references and whatnot, and other, any kind of work, background history, that type of a thing. And then it has been requested that they have an ability to meet a reading and writing standards exam that's done through KCC online. Because they will be charting, they need to read orders and they will be charting, so it's very important that they have those skills. So the selection committee, when you're looking at the selection committee for the scholarship program, we've suggested that it be an individual from each of the units, acute care, long-term care, and home health, along with a human resources representative, and we wanted to have the board involved, so if we would have, request a board member to be involved in the process as well.
Leslie, before you turn the page.
Yes.
How did you come up with $1,472.50 for student wages?
It's 155 hours to complete the course.
Okay.
So we're paying them 155 hours times minimum wage at $9.50, and that came out to,
And so that is, these are for non-employed, employed people.
we would
so
bring
these are-
them on, and that's on the second page.
Mhm.
They would be temporary employees while they're going through the class.
I see. So in essence,
Nope. Can't do that legally.
if they're currently employed somewhere, then this offsets their lost wages a little bit,
We're hoping.
or a little bit,
Yeah.
if they can get off work to do this.
That, or if they would like to give notice at their other job and concentrate purely on this. Because we did talk about the time commitment with 155 hours, and what was it, Charlie, that we figured they could get through the program and get certified within 8 weeks? Was that what we discussed?
Provided everything goes well.
Yeah.
Some of it is timing, how long it takes from when you finish the class, until you can take the test.
5 weeks and then
So if you get through the program, depends on how quickly you get through the online component. So if you just did that on a weekend, it might be less time. But the actual number of hours spent, 150 hours, I believe it is 100.
55.
Is that right?
155.
Is actual time when they're either in a lab, so working with the manager, or working with the patient. So 155 hours at 40 hours a week. You can see that that would be 5 weeks. And then you have the time period for when you finish, to when you take the test, how quickly that occurs. So you want to try and make it as reasonable as you can to any applicant. And knowing that if they're leaving their job, or they can't be without a job and without income. Because right now, when the students take their class, all students are doing this at their own expense. So there will still be those students that are going to do that. We are giving this to everybody.
And there's no obligation to them, like our other scholarship programs.
No, there can't be.
Specifically for the state
Yeah.
requirements for the CNA program, there are some restrictions.
No indentured servants, huh?
Unfortunately, no.
Well, if
We thought about that.
Good people.
That was the first thing that
I
came
think
to
this
mind.
is a great idea.
So if we flip to page 2, it'll just give you a couple of additional comments. So when it comes to the recruiting, because a lot of times it's like, well, how are we gonna find these people and who do we wanna target? Well, we wanna target the population at large. I mean, you never know who would like to start a career in patient care, and CNA is always the first spot. So a few thoughts with the advertising, that will obviously come out of human resources, but we have a lot of different venues. We've got the high school we can advertise, we've got our website, our Facebook page, we have the local newspaper, and then we can use the CHIP coordinator when we have a new one to do outreach to the community. Because you've got people, I think specifically about, you've got women who have been displaced and they're in the crisis center, and maybe they need some training in order to get back into the workforce. So there are a lot of different ways that we can get the word out there. We can even put it on our payroll notice for our employees, because a lot of times you find out about a job word of mouth, especially small organizations. So I think as far as getting the word out there, that we have a lot of different venues that we can take. So additional comments. sort of in order to get people interested in the program and get them engaged and hoping that they want to participate, we will take their temporary service and those hours they put in and apply it to their 500-hour introductory period. So once they're hired on in a permanent position as a nursing assistant, those 155 hours will go toward that introductory period to get their benefits to them a little bit sooner. I, of course, will have to write up, and these are just administrative things, we'll have to write up a job description for the program and the temporary positions. And then Charlie and I talked about the funding and what budget will come, you know, which budget that will come over out of, and that's to be determined. What will be in the best interest of Lake Health District moving forward.
And what happens if you have somebody like one of our own housekeeping employees or somebody that wants to go get this training? They'd actually have to cut and pay to do it, but.
They can apply, it would be open, I mean, we're an equal opportunity employer, so they would be able to apply. We could not discriminate because they're currently in another position within the hospital, and if they're a qualified applicant, we would throw them into the pool.
Is the amount of scholarships available going to be based on the amount of jobs that you have for CNAs?
Yes.
So it'll go up and down basically?
Yes, yes.
So the possibility of, based on that statement, the possibility of going through the program gives you a certainty of a hire, maybe,
No.
but the
It
possibility.
gives you a door that will open as
Yes.
long as you complete the training
Well,
and you do what's required.
And I
you
understand that,
are
but-
a strong student when you complete the
And,
program.
okay, yeah, and I get that, but
Yeah.
there's a real good possibility that if these people are selected to go through
Yes.
this program, they get a scholarship from us, they complete it and they do well, they might walk right into a job.
Exactly. Yes, exactly. And we really want to convey that to individuals that are successful in the program. They will have a job because we have a need, and that's why we're giving the scholarship. And, just talking with Melinda this afternoon, her staffing needs are going to double, and training starts in October. So we really need to get chomping at the bit to start recruiting and getting folks on board and getting this, trying to get this program built.
Are we pretty sure of getting 8 students initially? Because this, if you only got one student, it skews the numbers.
Yeah. I am not the person that can answer that question. I would,
To answer that, we get 16 students.
What's the minimum we would take to have a class? If we were in need of CNAs at the hospital and you had 3 applicants, would you hold a class for 3?
yeah, we've done that.
We have done that, we haven't done that often. We haven't done that.
We've also included Altair's training.
We have made it available to the hospitals in Altair and Cedar, and they've had students come up. What they're able to do is they get a boarding license that immediately apply to California, reciprocity, get their license in California, and they can start working.
Do you offer that person a scholarship?
At present, the hospital in Alturas pays all of their CNA students to go through the program because they weren't able to get to go through. So rather than treat it as a scholarship, if they get accepted to the program, they are paid at the minimum wage.
Who's our instructor?
It's Maribel.
Maribel, yeah.
Oh, so we have one on staff, an instructor on staff. Well, didn't Melinda do some of this CNA
Yes.
training here
Yeah.
just last
Mhm.
winter or something?
Mhm.
With Maribel,
Yeah.
Yeah,
and this would continue.
and we're still in need of CNAs.
It's a constant process. Being a CNA is a difficult job. It isn't always as glamorous, it's horrible. And some people find out that this is often their entry to the healthcare world. They discover this isn't exactly what they thought it was going to be like. Others, it is the absolute thing that says, this is exactly what I want to do. And they become an LPN and then an RN, carry on. So it helps define their career, often their career path.
And the different departments and the clinics as well compete for the employees. So long-term care is particularly physically demanding, let alone emotionally demanding, which it is as a CNA all the way around. And so if there's an opportunity for you as a CNA to apply for an MA position and you know the clinic's gonna train you to be an MA, well, then the clinic's filled their position, but now there's another hole for a CNA to fill in the long-term care. So those are kind of the challenges that we run up against.
I think this is a wonderful program to try out.
Well, no, we have to figure out where we're going to budget this, correct?
We believe we can manage that.
I'm just suspicious about those money spent. It's not gonna come from a position we haven't filled yet. I think it's a great program.
Well, in a way, it'll help offset having to hire travelers because they're incredibly expensive.
Absolutely.
So if you look at the cost benefit ratio, I think that will be ahead.
I pay overtime.
Yes, over time. You know, and then you've got employee burnout. So, I mean, there are a lot of, soft intangibles that this will impact as well.
Very good. I'd ask for a motion.
I move that we approve the CNA scholarship proposal as presented.
I'll second that. Those in favor?
Aye.
Aye. Thank you. Thank you, Leslie.
Well, thank you. HR recruiting, thank you.
Do we have any medical staff report tonight?
We do.
Okay.
So, Dr. Hussey would have been here, but due to his schedule and patient care, he's not able to be here.
1, 2, 3 equity pledge. You're gonna have to sell that one.
I've looked at that one.
Did everyone get a copy of this? I know it is a very short notice on this. There's a lot of push within the American Hospital Association to ensure that throughout the country, we are adequately accepting diversity within the hospital's employment. And so there's a movement within the state of Oregon to try and have 100% of all hospitals state that we are pledged to be as fair and reasonable as we possibly can. And we do not, that we encourage diversity and that we don't in any way, shape, or form discriminate against anyone. When we look at diversity, as I look around our room, we're probably fairly representative of the diversity within Lake County. We are a fairly homogeneous community, and so we don't have an enormous amount of diversity. We have some, and we appreciate all the richness that that brings to our community. But what this is saying is that we're not going to take any kind of stand that would not encourage diversity. So I would recommend that we take a positive position saying that not only are we, it's against the law to not allow for diversity and to discriminate in any fashion, but that we make it a public notice that we encourage diversity wherever is appropriate.
Don't we already have this policy?
We
Don't we
do.
already make that statement?
We say that we don't discriminate.
They say what?
We say we do not discriminate.
Oh, yes. I know.
This looks like the tip of the iceberg to me, where they're gonna have to do more and more and more and more of these things, and it's just wasting good time in my mind.
I don't have any trouble with it, but wasn't there like percentage numbers that we were supposed to fill out?
If we don't have applicants or we don't have individuals that come from a diverse background, we can't manufacture those.
So what sort of reporting burden does this come up with?
It's the effort and it's the continually growing burden of reporting.
Is this,
It keeps getting, it just keeps adding. I think when NOM started, here, a year and a half ago, we had this amount of reporting and it's now this, and that's beginning to look like that's just the tip. It's good.
Whose hands does this land in? Whose lap does this land in? Is this HR? Is this who takes care of this?
It will be probably a combination of all of the HR. There'll be some administration.
This is just a spin-off of affirmative action tracking. I mean,
It just is a continuing expensive reporting.
Is this something that's going to be helpful for us, or is it just an additional burden of reporting?
In an urban setting, this is a far more important thing. Sure. And so what you really get is we are offering our solidarity for urban environments where there is a much larger diversity. When we work on how many languages we're translating, do we have to accommodate? It may be 4, 5. In Portland, it may be 100. So it is a much greater burden in an urban setting than what we have. But it's still, it's one of those things that I keep trying to.
Do we have to do this?
No.
I would ask that you would.
I'll make a motion to do it, let's just do it.
Do I hear a second?
I'll do a reluctant second.
Those in favor?
I
Those opposed?
reluctantly, I will say aye too. I just don't get all this stuff.
That motion passed.
Thank you very much.
our reputation's at stake.
I understand. Larry, before I start my talk, is there anything you wanted to add about stuff that's going on in long-term care?
I don't think so.
Okay. Just wanted to give you that opportunity.
More coffee?
It's been kind of a busy week. As they will. I guess probably the most important thing that you would like to know is that as of yesterday, I received a call at about 5:30 or so that we had been the selected organization to get the contract. The commissioners voted unanimously to select Lakeview District based on the recommendation of the advisory committee. So, we are actively working on a whole lot of the issues. We'll be meeting on Monday, for example, a meeting by telephone with the Teamsters Union to resolve the issues, employee transfer, how that works, what that process means. Next week, the following week, the week of the 18th, we will finalize an agreement with the county, what the terms of the contract will be. So that we would anticipate having a board meeting last week of July for you to review, see the contract. I don't have a date yet. If we get the agreement put together quicker, we'll see if we can do that the week of the 18th. But our target is to have it completed by the 22nd. An agreement that everyone will have comfortable with. And that means both the county's attorneys as well as our council. Then I can go into as much detail and all the things that are with that. It just will be a lot of things that will be working. We
How long do you have to stay over?
have received notification that we have 2 grants. One is for, it's actually part of the joint powers agreement. It's not completed. That JPA for Oregon is not yet completed. But the 4 hospitals all agreed to, that's Hepner and John A. and Carney and us. With work now, we received total of $80,000 between the four hospitals. And we're going to be doing a one-year lean project with Purdue University to work on, right now our plan is to link between the clinic and the hospital, find ways to, that we all can learn to lean technology, to learn better about how to make our processes work better. This is a pretty exciting opportunity for us all to work together. Second is that we received notice that we had gotten a grant. We have not defined how much of the grant we'll get, but it looks like we'll receive about $100,000 with our match of $50,000. And this is for distance learning and telemedicine program through the USDA. So we anticipate we'll find out this grant probably at the end of the summer.
Is that Lake District gets that grant or here?
That's just Lake District. So, we have behind this a couple of monitors, and that is connected through the GOBI grant. GOBI, Greater Oregon Behavioral Health, got a grant for 20 different organizations to do video conferencing and programs for that. So that's they had received the grant, and we're the recipient. So that's really positive. Given that there are so many grant opportunities, we are looking for a grant writer to help us. We talked about that. We'll be interviewing that in the not too distant future. I have been attending the CCO board meeting as well as the local community advisory councils. So a couple things to understand about the CCO. I told you, I think, at the last board meeting that there looked like we would be getting money back as a CCO. And the CCO has done fairly well. In fact, they paid back as part of how well the organization has done. They paid back some of the investors, which is MODA, GOBI, 4 of the hospitals, and one of the large clinics. Some of their upfront money that they put in. But from our standpoint, it looks like, CCO met almost 13 of the required metrics, quality metrics that CCOs are held accountable to. We've been working certainly with the CHIP program, but also with the doctor's offices. For the Eastern Oregon CCO, that amounts to about $10 million. That will, for Lake County, and then we'll get the lion's share of that, but not all, somewhere in the ballpark of $100,000. So we should, we thought we would have the specifics, but I don't have all the detail yet. It should be by the end of July. But it was very close to whether or not we would meet the metrics that it was accomplished at the end of June. And we just haven't gotten all the dollars yet. So that's really positive. What's a challenge about this when we talk about how the number of and the level of meeting these metrics, we don't even know what they are for 2016, and we're 6 months into it, which makes it really hard for us to meet it. So we're going to be scampering the end of the year. We have a fair idea of what many of them are, not all of them. The state is still working on trying to determine what those will be. Part of it, the reason that they don't know is if we continue to do really well, then they'll take that metric off and pick things that are more difficult to do. So part of that process requires that we become a patient-centered primary care home, our rural health clinic. And we had an audit about 2 weeks ago to see how well we are doing. And due to the hard work of Nam and Juanita and many of the staff members, we will meet the criteria be a level 3 patient-centered primary care home, which also is a great advantage of the behavioral health component that we have. So by linking that, what that amounts to for us, aside from the amount of work, is in the ballpark of an additional $150,000 a year. So it's really important that we meet these criteria. We'll apply for that at the end of this month. And the auditors think we will meet not only 2016 criteria, but January 1, 2017 criteria for being patient-centered primary care home become more robust, and we probably will meet that at what we're currently doing. So that's a really positive thing. We will also be applying, we're using the same techniques and the same technology, so we're applying that for a clinic in Alturas, and the CCO in California has a similar program. So if we can get both, that will help both organizations. One of the things that's really, that feeds in with that, these metrics, the CCO has elected to give away to 800 new mothers crib and sleep sack and all sorts of things to help improve the outcome of new moms and their babies. So that's going to be going, we don't have 800 deliveries in Lake County, but we have lots and lots of patients that will benefit from this. So this is a really great thing. If we had 800, we'd have
You know.
And I only wonder what's going. Something in the water. We received our final order for our certificate of need. I talked to you about our temporary. So we have our certificate of need. Please keep in mind that we have to have a plan that the Department of Health is DHS approves by the time we are ready to move in of what we're going to do with the additional 23 beds, or we lose that license. So that's the stipulation. They didn't change it. So we've got about now 9 months to figure out what we're going to do and get them to agree to it. We'll be working on that. I think one thing that when we are involved in our CHIP program, Community Health Improvement Program, there are a lot of very positive things that are happening, keeping the public engaged, but also keeping our partners engaged. It's been sometimes a slow process, but at the same time, we have a lot of really good input and how our focus works. It was announced at our last meeting that the Klamath Food Bank, or a food organization there, is giving away food every week. And so one of the members of the community is going and delivering that here in Lakeview. And the first week they did this, they gave away 2,200 pounds of food. And it's fresh food that is from the grocery or from producers. So that's really a great thing for our community. As you know, we have a rare participant who's been helping us trying to determine our food insecurity for Lake County and come up with a plan of how to try to change some of it. Food insecurity means those people that aren't necessarily, that are hungry, suffering from hunger, but are uncertain of whether or not their next meal will be. So I think that's a very positive thing that's going on with the CHIP program, as is the Go Girls program, advisors program, and the dental sealant program that's working with the school. So a lot of good things related to that. As you know, I have been involved in what the Hospital Association calls the PATH program. And I'm a part of the PATH task force, progressive thinking for hospitals. And at our last meeting last week, this task force represents 50% of all of the hospitals in the state of Oregon. So Providence Systems, Samaritan, St. Charles, Kaiser, all the different organizations, trying to look at how do we address ways to improve the access to care and the cost of care. So you're hearing some of the things we've talked a little bit about. How do we improve our cash pay component? Or how do we make available to the public areas where that we can make it more affordable, or make it more reasonable. We'll be coming out next week at the annual Hospital Association meeting of all CEOs. Come up with a plan. I'll be able to advise you after that, and then taking the steps for this fall, all in preparation for the next year's session, which will be January 2017. But we're making some good progress, and I'm pleased to represent Lake District Hospital. That's what I have to talk about. Do you have anything I can answer? Questions I can answer?
Thank you. And Jen prints up the old mission statement and the new mission statement, and I got, and I sent it out a month ago or so. And the only one that really mentioned anything to me was Judy, had some suggestions, and maybe that's a good place to start.
Okay, I have a concern about listing specifically all of these 9 items that we're going to do. I think that maybe it's a little bit of the background that I have, but I think when you are specific with these, you are tied into a mandatory that you will do. And there's a few things there. Well, the one that really hit me a little bit is the durable medical equipment services, because we are just getting that started. We don't know if it's going to work. I really like a policy that covers everything here, but is more generalized.
In a
in
broader
its
basis,
resolution.
yeah.
Mhm.
Sure, that's a good thought.
Mhm.
Anybody else have any thoughts? I just sent this out as a place to start, so.
Yeah, when you talk about the residents of the district and outside the district, you know, where it benefits the district, I like a simpler statement. I don't know if that's, I mean, we're required to provide services to everyone, whether they're a resident or not.
Was there
But
a?
that's not our focus, our mission. Is that our mission?
Yeah, and you say where it's required by the Oregon statute. I mean, we're required to provide services to anybody who walks in.
Chuck, was there a specific reason that you wanted to make a change to this one? To the
Yes,
old one?
because it started right off, it's Lake District Hospital long-term care facility, which we aren't anymore. We're Lakeview Gardens and Lakeview Health, Lakeview Hospital, Lake District Hospital. And then we've got other entities involved now, Goose Lake, and so on.
We could adapt that to this old language though, couldn't we, to make it, because when you read through the old mission statement, really truly, I think the support of the following, the items are basically all covered with what you're saying in the
Yeah,
middle.
you can reword that and do it. They have to change the top, like Health District DBA, and you have to do something with the DBA.
We could just put Lake Health District,
That you could do that.
just get rid of that or something.
Okay. All right, let's try that. Okay.
One thing that, when I looked at lots of different organizations' mission statements, let me give you an example of one that I pulled up. as a possibility. This organization says they strive to advance the health and wellness of our community by providing excellent healthcare services, patient safety, and experience at reasonable costs. Our highly skilled and engaged team of physicians, staff, and volunteers ensures patients are well cared for while within our service. If we don't, I mean, it's one, when we think about our mission, we have lots of things that we deliver in different ways. But if we can make it as simple as we can, it does allow us to, we are a health district. Yes, we do provide hospital service. That is one of the things we do. So we talk about it. And we are becoming more involved in not just the health of our population when they come to the hospital, but the health of our population outside of the hospital. So we talk about population health, those kinds of things.
But it needs to, you have to think about, if you're talking about patients, now we're talking about residents in long-term care. And they're not always considered a patient.
So, and that's why if you say our
Community health, and we want to
just community, wherever the community is.
that little book that we were reading is, points out that whatever you do, it should be patient-centered and focused, not like some of this talks about the facility. As we're not here just because of the facility, we're here to be for patient health, community health. That's
Good point.
I like a mission statement that is, something that's fairly short yet concise. Both of these mission statements, I think, are long on detail. What was that one you just read, Charlie?
This organization, and this is just a sample. So, strive to advance the health and wellness of our community by providing excellent healthcare services, patient safety, and experience at reasonable costs. Our highly skilled and engaged team of physicians, staff, and volunteers ensures patients are well cared for while at the hospital. Now, again, that may be, we don't have, this is just a sample.
Right, I understand that.
Yeah, the only thing I would object there is you're stating you've got a highly skilled staff, but I think our mission is to have a highly skilled staff.
I think having a statement like that says part of our mission is to have highly skilled staff and to maintain that.
I think it's used as reassurance to the community too, that we have highly trained staff. If we're stating in our mission statement, then we sure as heck better have a highly trained staff. So it kind of depends on the message you want to deliver to the community.
I look at the mission statement as a goal statement in my mind.
What is to care for our community? Isn't that our mission statement? I say it all the time, now I can't say it.
That's our,
That's our value statement, isn't it?
it is a mission statement. This other mission statement from '93 was more robust. We do have that smaller care for our community with compassion and
Through excellence and teamwork.
That's one
excellence and
sentence,
teamwork.
yeah.
Something in compassion. How are
We could almost use the opening paragraph in this old mission statement and just
There is respect and compassion.
improve it a little bit and add with compassion.
But what isn't that our mission statement?
So we have two mission statements.
No, we want to have one.
So the short version will be
No,
She
To care for our community with respect and compassion,
Right.
with excellence and teamwork.
It's on our job description.
Oh, yeah.
So that's our mission statement.
This one.
This one little thing, I pulled it out of that book.
Charlie, I thought we had talked about this one other time since I've been on the board. Did we not just never change it at that time?
We did. This one that we, the shorter version that we use is the one that we have been using throughout the hospital for a long time. This more robust mission statement that came from 1993.
All inclusive.
So Chuck, when you talk about the goals, so generally there's a couple of different types of statements. There's a vision statement, and that's where you set your goals, and then there's the mission. And I'm just using my really expensive MBA grad school
I
knowledge
don't have that.
that I just got. I want to get my money's worth. So when they put you in marketing and branding and all that kind of stuff, they talk about developing a vision statement, and that's
That
where
came
you.
from the board book that I updated last year and handed out.
One time.
Well, isn't that our mission that we just read on that?
That was
Isn't that
our
our
mission
mission?
statement that was developed by a board, previous board.
Right.
I remember when
That's
they
the
did
one.
it.
That's the one we worked on.
This one, no, this has been moving longer.
Has it been even longer?
Yeah, because I remember a different board, yeah.
There's a different statement here.
But I like that.
Yeah,
I
well,
like that a lot.
it's very clear and to the point.
Concise.
Mm-hmm. Yeah, so, your vision statement or your goals, your mission statement is basically what
If
you
you
plan on
want the
doing.
public to read it
Yeah.
and pay attention to it, it has to be that, it can't be this.
It might be that one of the things we look at is taking the little bit more part that you worked on and focus on a mission and then our vision statement.
And then you can have a value
And
statement.
and so maybe if we take some of these, how about what we do is we take these comments that everyone's been making now, we'll take and send that out as vision and value statements so that we can adopt these really good ideas,
Mhm.
but use the shorter version that we had as a mission statement and use that.
What's your thoughts on that one last sentence of my header under the one I proposed? I took this pretty much out of the book. Those services will be provided when the manner is in the best interest of the patient, resident, or client to care for and prevent healthcare events. Is that too much detail?
Fills me with
Good
dread.
statement.
Kind of fills me with dread.
It does, okay.
So we want to keep it positive.
These are good suggestions. We can work on this
Yeah.
and come back with some recommended changes.
Okay.
Or some draft.
And in order to fulfill the mission statement, I think that's a separate document, and that, all those are good. That he's got proposed here, but that's not,
I'm all for getting a nice, simple, broad statement and keep it short. I have no problem with that. I just took the old one and kind of modernized it.
Maybe we can make some suggestions and provide to you and then see how you think about it from that.
I think the other thing we want to think about as you develop that is something that is a long-standing statement and something that is not always up for correction, amended, and crossing out topics that we no longer are providing. That's the problem with line items, and just mentioning everything 1, 2, 3, 4, 5. I think you don't want to do that. I think you want to be general in those statements.
It's a good suggestion.
Okay. We'll let Charlie work on it a little bit, see what we come up with.
Well, I'll come up with some couple suggestions and then send out, see if, what you think.
Sounds good. It is 8 o'clock, we will take a 10-minute recess to come back to our executive session under the whole